So first thing is first, I am going to enlarge the screen depending on what parts. Ooh, I didn't mean to do that. Well, that's what it does. Depending on what parts we go on. So it could be easy for you to actually read. This is the medical terminology segment of our phlebotomy course. And first thing is first, I want to go over the brownish section here. Well, with the words. And I know for sure, Alex, you're probably going to be familiar with a lot of this stuff since you have a background a little bit with the lab or some of the anatomy while you're in school. So what I want to, the reason why I pointed out these particular three terms, because I want you to be familiar with the different departments that is in the lab. Okay, it's more than just this three, but these are big, important factors of what's department. So what I mean by that is that once you actually learn the order of draw and you learn what test goes in the different tubes, once it's delivered to the lab, it goes, some tubes go here, some tubes go there, some tubes go there, some tubes go there. So when you are trained as a lab technician later on, you will work in the different departments that's within the lab. Okay, so I want to be able to, for you to be knowledgeable enough to understand some of these terms. So first thing is first. Let me be sure because I was able to read the whole screenshot. Oh, thank you, Alex. I'm sorry, I'm just seeing that. Great. So first thing is first, let's go over the terminology here. I have three words out, and one is toxicology. That's first. I have it kind of separated, so when you actually sound it out, it's toxic and ology. I don't know if you all are familiar with the term toxic. You know, a lot of people use it in forms of relationships, like, oh, they're too toxic for one another. You know, they're not good together. Toxic, too much of something that is bad. So, for example, you can take too much of drug. First off, drugs, depending on what it is bad for you. But let's just say medications that the doctor prescribed to you on a day-to-day basis. Medication is considered a type of drug. It depends on if it's legal or illegal or if it's a controlled drug substance. So toxicology means the study of toxins. Toxic mean is too much for your blood. Rather, it's you drunk too much alcohol, you got alcohol poisoning. That means you have a toxic level of alcohol. Rather, you took drugs, illegal, or the controlled substance. And what I mean by controlled drugs, your stuff like your Xanaxes, your Vicodins, your medications that is legal, but because of the tolerance that it has on a person's body, it is a form for you to, it is a such thing of you to take too much. So toxic, too much in your system that's bad for you, it can harm you. Ology means the study of. So if you see from now on a word that ends in OL, OGY, it means the study of whatever the beginning of the word is. So, for example, how can I best explain it? If you know anyone that goes to the heart doctor, cardiology, cardiac means heart. Ology means the study of the heart. Cardiologist is a doctor that specializes in the study of the heart. Okay. So what I just need you to remember is that once you see ology, you know that it is the study of. Toxicology is important for you to remember in phlebotomy because toxicology is a department within the lab. That's where all your drug test goes. That's where the blood work goes when a person has to take a drug screen, rather it's from the urine, from the blood, or they took hair follicles. It goes to the toxicology because That particular blood, urine, or lab is trying to see how much of this stuff is in your system. Okay, so it goes to the toxicology lab. So what I want you to remember or study, toxicology means the study of toxins. It's not a toxicology don't per se means the person that is the person, the doctor that studied toxins. When you go into the word that says ologist, now the word means that is a specialist, a person that specializes in the study of toxins. Just like phlebotomist, that is a person that carries out the phlebotomy career every day. I mean, that carries out phlebotomy every day as a career. Okay, so toxicology. And for some reason, I don't know why, I'm just now noticing it, and it's been like this for weeks, that I'm just now seeing that I don't have the page number there. It's no way around how I explained it. It's just as simple as pie as I feel, that's like that. But if you do want to look at it in your book, I will definitely add the page number of toxicology on there. Give me 1 second. Okay, I'll put it on there. That's probably why I don't actually have it on there, but I'll put it on there. But it's really simple for you to just remember toxicology. It is the study of toxins. If you see the word toxicologist, it is a doctor, someone who has a degree that specializes in the study of toxins. Okay, moving right along, this word is pronounced microbiology. There goes the ending suffix of ology again. So even though you may not know yet what microbiology means, at least it'll tell you that ology, that means the study of whatever that beginning of that word means. In this case, microbiology means the study of microorganisms. This is the person that studies the bacteria, the viruses, the funguses. Hello, Martha. That studies all of those things that we learned that is a microorganism, the germ. Okay, so for example, you know how we all dip urine this weekend, and then the urine was abnormal, so we collected a urinalysis and we connected a urine culture. That urine culture, basically, if you remember correctly, or if you remember without a pause in your brain, culture CNS means that is going to the lab, it's going to grow for 24 to 48 hours, and it's going to let the doctor know when the results come back what bacteria is really in the urine. What is the name of that bacteria? The sensitivity tells us, remember, what antibiotic the doctor is going to order to help us to kill that bacteria. We can all have that same bacteria, but we are as an individual, so we may all be on different medications. That's the purpose of everyone having their own culture. The doctor may be experienced to know, like, okay, if you all have a strep throat, that is a bacteria, streptococcus, blah, 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 a big word, okay? He may know that amoxicillin usually works, but it may not work for all of us. So that's why even though he prescribed amoxicillin, he still sent off that culture that the nurse swabbed your throat with, took it to the microbiology part of the lab. It sat there, grew underneath the light, underneath the microscope, whatever the lab does, for 24 to 48 hours. Then it was able to be resulted to tell the doctor that, yes, Miss Chopin does have strep throat, and that, yes, amoxicillin will help her. So she needs to continue taking that. So microbiology, the study of microorganisms. Microbe, the study of organisms. Microbe is microbe, the organisms, the germ. the bacteria, the virus, the parasites, the fungus. All of that goes to the microbiology department. Okay, so microbiology, the study of microorganisms. Okay, now next, hematology. Hematology, we still have the suffix of ology. Okay, and any prefix that you see with HEMA or HEMO actually means blood. It is pertaining to blood, BLOOD. So in this case, hematology is how you pronounce it. It is the study of blood. You may have been with a loved one or with someone that was hospitalized or seen at the doctor's office, and they would say, well, you're such and such, I'm referring him or her to see a hematologist. Hopefully them words will strike up to you. Like, okay, that's a doctor that studies the blood. Okay, that's the doctor that specializes in the blood. There is a hematology department in the lab. Okay, hematology is a big word often that you will see working as a phlebotomist. All three: toxicology, microbiology, hematology. Okay, the study of toxins, the study of microorganisms, the study of blood. Remember, the study of toxins is anything that is too much for the blood and it can harm you. So rather it's drugs, rather it's alcohol. And remember, drugs can be legal drugs. A doctor can put you on a potent antibiotic that I know for certain is called vancomycin. If you get too much in your system, it'll cause ringing in your ears. How does the doctor know if it's too much in a person's system? If you remember yesterday, before the whole breakdown of the internet I had here, one of the most common complications was there is certain medications that you have to draw at a time manner. You may have to draw before the patient takes the medication, and you may have to take and draw the blood after the patient takes the medication. Some of those medications are those. And that's why the doctor is trying to get the patient to a therapeutic range. But that's not for you to know that, oh, vancomycin is one of those drugs. That's the doctor's job. If the doctor orders certain blood levels that I'll get into tomorrow, because we're meeting tomorrow as a regular schedule, it's called special collections. You need to know. So toxicology is not only for illegal drugs. It is for prescribed legal drugs as well. Just know that if it goes to the toxicology department in the lab, that means the doctor is trying to find out if it's too much in the patient's system, in the patient's blood. Okay. Microbiology, the study of microorganisms. Remember, anything that's a culture, remember the doctor can order a culture on any of our bodily fluids. It could be blood, urine, saliva, mucus, throat. Somebody can have a bad wound, sore, you fell down, and for whatever reason, your sore turned to a bigger, what we call wound in healthcare, and it's not healing properly. And matter of fact, it's getting worse. And instead of seeing pink tissue, you see green, yellow. Well, it's a culture to be done on that. The nurses, majority of the time, will swab it with the same similar Q-tip, and it will go to the lab so the doctor can figure out if there's bacteria laying in that wound, which is why it's not healing. Just remember, a culture can be done on any bodily fluid. And if a culture is done, ladies, it's going to the microbiology department in the lab. Okay. Hematology, the study of blood, HEMA. Okay, HEMA or HEMO, hemo or hema. It means blood. Okay. So those three right there, hopefully my explanation was understandable, but those are important to know what they are. So when you see them on a quiz or a test, you will be very well aware of what they are, okay? And it will not be tricky questions. Long as you know the definition, you should be fine, okay? If I tell you that toxicology is the study of toxins, it's no need for you to check, to mark an answer that is the study of Xanax. That can confuse you because I just told you that they can be legal drugs. But toxicology simply is the study of toxins, too much of anything. It's not just pertaining to Xanax, okay? So in that way, if you choose Xanax, that means you're keying on just on the medication, but that's not exactly what toxicology means. It means the study of toxins, and anything in your blood that comes back too toxic for you means that it went to the toxicology lab so the doctors can see your levels. Okay. All right, moving a little forward, I have what I call the 4-H words. These are very important to know, very important to know the difference between all 4 of them. Because if you haven't noticed already, they both start, all 4 of them start with HEMO or HEMA, right? So if you listen to me talking about hematology, what you should get out of it so far is that these words have something to do with blood, okay? So moving right along, let's talk about the first H word. I have them noted in purple. They are very important. The national exam have all 4 on there, and they have them on there multiple times. So this can be a case to where if you don't get one of them right, then you can get the other one wrong as well, because they ask you these things in so many different questions, in so many ways to confuse you, okay? First things first, our first H word is pronounced hemostasis. Hemostasis. It's on page 35 in your book. 35 is the beginning of our learning, which is basically chapter 3. I would like to say, if you study this, it will be simple. Hemostasis means stopping the flow of blood. It's a way for our body to repair itself after injury. In phlebotomy life, when we take that needle out and apply that gauze and have our patient to hold pressure, we are creating hemostasis, okay? So from now on, and especially this weekend, I'm going to throw questions out here and there, and I'm going to ask you, okay, the blood has stopped, so what has been created? Hopefully, you will study enough to at least remember hemostasis. The suffix of this word stasis means stop. So if you see stasis on any other word at the end of any other word, it means stop, okay? Stop, stasis, stay still. So hemo, I've already explained, means blood. So when you put those 2 together, it's stopping the flow of blood, simple. And in phlebotomy, we just think about when we hold pressure for those 3 to 5 minutes, we are creating hemostasis. So when you lift up that gauze to make sure that I'm not bleeding no longer, then you say, okay, you're good. In your brain, okay, hemostasis is there. You put the gauze back down and you go ahead and secure it with your Band-Aid tape or Coban. Simple, hemostasis. In your book, on page 35, it states at the top, the root of the word hemo means blood. The suffix stasis means stop, slowing or stopping. So put together, hemostasis is stopping the flow of blood, simple. So in any other first aids, someone gets shot, someone gets stabbed, someone slides across turf, football turf, and you start bleeding. In any other aspect, just remember in first aid, when someone is bleeding, you have to hold pressure to stop the bleeding because you do not want your patient to bleed out. So because they were injured and bleeding occurred, you hold pressure to create hemostasis. That is the body's way of repairing itself after an injury. We know as a phlebotomist, when you did insert that needle, you didn't on purpose injure the patient, but because you broke through the skin, it's used in that type of term, but you still want to hold pressure. So hemostasis. Okay. I think that's the most easiest way that I can put it. It's no use for me lingering over this word. Hemostasis, stopping the flow of blood. Next word, hematoma. If you remember, you probably remember that on the video we saw this weekend when we learned how to insert our needle with the angle and those type of things. So on page 131, it explains to you about hematoma. So in my ways of explaining hematoma, hematoma is a collection of blood in the tissue. It's basically a blood clot underneath the skin, and it creates a bruise on the skin that we see. And I think I started explaining this on Saturday. So hematoma is a collection of blood in one spot. Either you can see a bruise on the skin or you'll see an elevation in the skin. Okay. And how can a patient develop a hematoma? Okay. If the needle is not fully in the vein on insertion, it can cause a hematoma, meaning the bevel is halfway in and the bevel is halfway out. So blood is coming through, some of the blood is coming through the needle, but some of the blood is leaking through the tissue in your skin. And because of that, the blood is circulating in the tissue. And if it drains enough blood, because you're not seeing it, so now it's leaking in the tissue, but it's rising up because so much blood is now going into the tissue, okay? Another reason a hematoma can develop, if you remove the needle before removing the tourniquet, remember the process of venipuncture when you're done with your blood tubes, tube, tourniquet, needle. Never remove the needle before the tourniquet, because remember, if you remove the needle, oh, I'm talking so fast. If you remove the needle before removing the tourniquet, not only would blood start to sip out the injection site or the site, but it will also be forming in the tissue because the tourniquet is still tied. Mistakes will happen. All I can tell you is that you need to be quick with it. So let's just say you pull the needle out sooner than expected. Hurry up and pop that tourniquet and grab that gauze. That is why all your equipment needs to be in your reach, close to you. So in case something happens like that, you can be quick with it, okay? Remember, it is okay to take the needle out when the tube is still attached, only if you didn't get any blood. Okay, let's just say you were unsuccessful. So you pop the tourniquet and take the needle out because you got to discard all of that, to the whole evacuated tube system anyways, because you didn't get any blood. But if you did get blood, the process is tube, tourniquet, then needle. Needle is always last. A hematoma can develop if that needle is removed before removing the tourniquet. Last but not least, if you do not hold enough pressure on the site to create hemostasis, let's just say you have your patient hold pressure and they're barely touching the gauze. Well, you're not helping the hemostasis to be created. So in otherwise, the blood is confused, like, am I to stop or am I coming out the site? So that's why you need to hold, the patient needs to hold firm pressure to completely stop the bleeding. Otherwise, if they're barely tapping it, the blood can be seeping out the injection site and seeping in the tissue because it's partially blocked and it's not completely blocked to where it won't come out the site, okay? Hematoma, a collection of blood in the tissue, as known as a blood clot underneath the skin, and it can cause a bruise on top of the skin. How can a hematoma be created? If the needle is not fully in the vein on insertion, or if you remove the needle before removing the tourniquet, or if you do not apply enough pressure at the site, okay? Hematoma. Remember, if you also see a hematoma developing while you're in the midst of getting the blood, pop the tourniquet and just stop what you're doing. You don't want the hematoma to get any worse, okay? As long as you haven't stuck the patient for the second time and the patient is okay, because that could have spooked the patient a little bit, but all you do is just go to another site and draw blood, okay, if the patient allows you to. The third H word is pronounced hemolysis, H-E-M-O, lysis, hemolysis, okay? That's on page 125, and what that is red blood cells in the blood tube has been destroyed. Blood cannot be resulted if the red blood cells in that blood sample has been destroyed. It is very imperative that the red blood cells is very visible to when the laboratory tech starts to result the blood. So if the red blood cells in those samples are destroyed, then we cannot result the blood, and whatever that sample or that test is, the patient will have to be restuck again to get that one, okay? If all of them is hemolyzed, then the patient have to redraw and get all the blood samples. How can you hemolyze a blood sample? Well, you know, once we actually done with our tube, we already talked about how we have to invert our tube in a figure 8 motion, depending on the CLSI standards, how many times each tube's supposed to. We'll talk about that tomorrow. Well, let's just say you took them all out and you did this. You was just shaking them. And then you did this, shook it like it was some, you know, some medicine that you're gonna take. Well, you can jeopardize that blood sample from being hemolyzed because you vigorously shook that blood tube. We want to gently move our tube in a figure 8 motion to invert it, okay? If you are the transporter, meaning you went to my Quest lab and picked up the blood samples out the box outside to take it to the lab, but let's just say you picked it up and then you threw it in the backseat of your car, okay? It could be jeopardized of being hemolyzed. How would you know if the blood is hemolyzed? Well, you'll know when the result paper come back to your lab and it says such and such, Juanetta Chopin and all my blood samples that you drew, it'll say hemolyzed, hemolyzed, hemolyzed. The patient just have to come back in and get their blood drawn again, okay? So that is the main example that you're gonna see about hemolyzed. Know that hemolyzed means the red blood cells have been destroyed in that sample, and your blood can be hemolyzed if it's vigorously shaped, okay? Hemolysis and hemolyzed means the same thing. It's just hemolysis is the term and hemolyzed is the term in past tense because now the red blood cells have been destroyed. So the samples have been hemolyzed, okay? And that is explained also in your book on page 125. Hemolysis is the destruction of red blood cells. If a tourniquet must be released due to excessive time before completing a venipuncture procedure, the phlebotomy technician must wait at least 2 minutes before reapplying the tourniquet to the same arm. And we'll talk about that on tomorrow. And then also vigorously shaking the tube. But what I want you to remember is the vigorously shaking the tube. That's how you're going to be tested. And of course, that's important to know in real life. You don't want to purposely cause those tubes to be hemolyzed. But sometimes it could be something you didn't do. It can be something that the transporter didn't do, and it comes back hemolyzed. Again, you can't be sued for somebody's blood work being hemolyzed. The patient just have to, you know, come back and get their blood drawn. But on the other end, you just need to know what can cause the blood to be hemolyzed, okay? Our next H word is pronounced hemoconcentration, H-E-M-O concentration, blood concentration, basically. It's also explained to us on page 125. What it means is it's an increased level of blood concentration in the tube. For example, the reason why if we have blood in our tube, Akila, you said you can't see me?
Right now, I can only see the whiteboard, but I can't see you. So
are you on your phone or tablet? Because you may just want to switch between screens.
Okay, so I'm on my phone, but like when the whiteboard is up, when the whiteboard is down, I can see you, or I can slide over and see like everybody. But
Uh-huh.
when the whiteboard comes up, I only hear you, and I don't know how to see you at the same time.
Can anybody help her if y'all on the phone, or is that the same for
I
everybody?
think I think that's for everybody because I'm just on the whiteboard too, and I can just I can only I can only hear you, and I don't know how to move it back to that either.
Okay, okay. Well, that's good for me to know. Well, vigorously, Akila asked me to demonstrate um vigorously shaking the tube. And vigorously shaking the tube is just shaking it at a fast pace and at a heavy rate. When I showed you how to invert the tube in a figure 8 motion, gently side to side, just remember gently, because when you're tested, it's not going to be a person demonstrating vigorously shaking the tube. You just have to know that when you see it, the blood sample can be hemolyzed if you vigorously shake it. And the word, if you understand what the word vigorously mean, that means you are aggressively shaking that tube, or you are aggressively doing something. So that's what vigorously basically means. And if I
Okay.
remember, if you remind me, when I stop unsharing my screen, I can do it again. But it's basically, abusing the tube, basically, you just don't want to vigorously shake it with force. You just want to gently invert it from side to side in a figure 8 motion.
Okay, got it.
Okay. Hemoconcentration. Oh, that's where I was at. So hemoconcentration is an increased level of blood concentration in the tube. What that means is if you ever filled up the tube and you got good blood return, you were successful. And let's just say you popped the tourniquet and you took out the needle with the tube still attached. That can happen in real life, right? Mm-hmm. If you take out that needle with the tube still attached and take it out the skin, you'll hear a sizzle like it's sizzling. That means the leftover blood and air from you withdrawing that needle with the tube still in went into that tube. So that means you can jeopardize that particular tube having a high concentration in blood to where they can't really, what's the word? The little bitty bubbles that form in certain things. Your blood tube, if it have little bitty bubbles at the top, that means that your excuse me, that means that your sample has too much concentration in it. So when it's resulted in the lab, the medical director may not be able to see the components of that blood. So how can you prevent that? And this is one thing about the tourniquet that I haven't talked to you yet about. When we tie the tourniquet, we do know that the tourniquet goes above the site 3 to 5 inches. So if you're drawing in the anticubal, oh, I forgot, y'all can't see me anyway. If y'all draw in the anticubal fossa region of the arm, then that means you put the tourniquet 3 to 5 inches above, which is kind of almost going to the shoulder. If you're drawing in the dorsal metacarpal veins, which is our hand veins, the back of our hand, then you want to tie the tourniquet on the wrist, typically above the person's bracelet or watch. But another thing that I need you to know is that typically a tourniquet, when you're in the midst of drawing blood, a tourniquet is not supposed to be tied in place for 60 seconds, which is equivalent to a minute. So you see on Saturday when we were actually learning how to tie a tourniquet and feeling for veins when we were, I think if I remember Miss Tracy said, oh, I'm about to die, or it's tight. Or if you leave it on long enough, you'll start to feel it and you can cause your patient, to kind of go numb in the arm. So if you think the tourniquet has been left on for 60 seconds, let's just say you tied the tourniquet, you use your alcohol to just feel for the vein. Let's just say you're feeling, and then you try to press on the vein to make it pop out a little more with that finger, like I told you, to bounce on the vein, because the longer the tourniquet is on, the better the vein will pop out. So let's just say finally the vein has popped out. instead of being ready to draw, you need to pop that tourniquet and let the arm rest because it's been over 60 seconds. You can cause that blood when it comes out of the arm to already be having a concentration, hemoconcentration. Okay, so for textbook purposes, hemoconcentration is too much, it's increased blood concentration in that blood tube. If you leave on the tourniquet longer than 60 seconds, you can cause high concentration in that blood sample, and it can be on the urge of not able to be tested. So in real life, even when you're learning, because we're not at a race, when we draw blood on each other, once you feel for the vein, it was probably most likely already a minute it took for you to feel, unless someone has big bulging veins and after you feel and wipe with alcohol, you ready. There's not a problem with that. But if you feel that it took you a little over a minute to feel, pop the tourniquet, say, okay, I'm gonna let your arm rest. Make sure your equipment, just look at your equipment again, your supplies, make sure you have everything you need. Typically, it's supposed to be a 2-minute wait in between. And then reapply the tourniquet, and then you'll be ready to stick. That's why the faster you get with finding veins, you'll be able to tie the tourniquet and go ahead and do your venipuncture procedure there. But in your textbook sense, hemoconcentration can form if you have the tourniquet tied in place for longer than 60 seconds, which is a minute. Did I lose anyone on hemoconcentration?
No, no.
Okay, thank you so much. My throat was going dry. So these 4 words, ladies, are very important to know what they are, what the definition is, and what can be, how you can cause these things. Hemostasis, hematoma, hemolysis, and hemoconcentration. I would advise you, if this is you, make flashcards with this. It's going to be on the exam. It's going to be. It's going to be. And I gave you the causes of what you will see. I didn't give you the causes of anything that you won't see. So if it tells you, according to, if you vigorously shake your tube, your blood sample will be in jeopardy of not being resulted because of what? And they'll have all 4 of these as an example. Hemostasis, hemolysis, hematoma, hemoconcentration. They'll have that on purpose because you know it's an H word, but now you're trying to figure out which one is the one that you vigorously shake the tube. So then hopefully by then you'll be confident enough to be able to process eliminated or either know directly that's hemolysis. Because when they give you these questions, they're going to put all the H words as a choice. You just need to know which one according to the question. Okay, so study it how I have it on here. And then also it'll be on my quiz to even help you to test yourself again. Okay. Now moving right along, I'm going into my little blue purple box. I've already went over arteries and veins, but just to kind of go over it again, remember our arteries are red in color, and that is the oxygen of blood that goes away from the heart. So when it rejuvenates in our heart. So basically, when it goes out our heart, it's oxygenated. Vein, which is venous blood. So if you hear anything that says venous blood, that means vein blood, okay? Remember, blood is red, but this one is more of a darker red, and it's because it's deoxygenated blood that is going back to the heart. So that's the circulatory system that starts with our heart, okay? We have bright red blood, which is artery blood, and we have more of a darker blood, which is venous blood, because it doesn't have any oxygen. Remember, as phlebotomists, you never draw from the artery. Can you get blood from the artery? Yeah, but we drawing from the veins because the arteries is too deep. You actually have to go through a specialized training to draw blood from the arteries. Even nurses don't draw from the arteries. Typically, doctors and respiratory therapists draw from the arteries. If you work somewhere and they tell you, oh, we train you to draw from the arteries, well, it's okay. because you're working under that doctor's license, you know, if you want to go ahead and learn how to draw from the arteries. You never know. You may work in a small place and they train you on everything. Just remember, if I'm telling you that it's not in the scope of your practice to work as a regular phlebotomist, if you work anywhere and there's a nurse practitioner or a doctor, they hold the license that they say, I've trained her, or she's had the appropriate training. So she's trained to draw artery blood. So if anything shall happen, his license is on the line, or her license is on the line, because they allowed you to draw blood from the arteries in their clinic, because that was part of your job duties. Okay. Now, you may work somewhere and they tell you that, and you maybe be like, I don't feel comfortable, you know, drawing from the arteries, even if you train me. That's between you and them, whatever they tell you, you know what I mean? But I'm just letting you know, even when you go further, you may want to go to nursing school or you do something else. If you don't learn it in your training, but yet you work somewhere that trained you to do it, it's still okay, because you're doing that under their license. So you don't get in trouble, they do, okay? But they're giving you permission to do it under their license. I hope that makes sense to you, because it's happening a lot. Like with CNAs, certified nursing assistants, you have to hold a separate license to pass medication that makes you a certified medication aide. But they have a lot of facilities that take CNAs and train them on how to pass medicine, because they're working underneath that facility or that director of nursing license. So if anything shall happen with the patient because someone gave them the wrong medicine, they really don't hold a certification for it. The director of nursing did, but they gave you the permission to do that. So just be sure, if that ever happens, that it's in your job description of proper training, because I ain't gonna lie, in these day and times, you need to have some kind of paper trail of signatures of both parties, okay? Because they are doing a lot of cross training. They are. And you go to school for one thing and you do this, but they train you to also do this, so they can pay you or not hire so many people because you do all of it, okay? So just be mindful. So you don't draw from the artery blood, but just know arteries carry oxygenated blood and it's bright red, and veins carry deoxygenated blood and it's more of a darker red, just like the image to the side of it. Veins carry oxygen depleted blood back to the heart. Arteries carry blood that's oxygenated, rich in oxygen, away from the heart. So it's just going in a cycle motion like that. It's just that veins are more upper in our tissue and arteries are more deeper in our tissue, okay? And this is also another image of, I have a figure of this lady, and it also shows you that veins and arteries start from our heart. That is the motor of our body. And you see, we have veins and arteries everywhere, okay? We have pulses everywhere. We have veins everywhere. But just as phlebotomists, we draw from the antecubital fossa and we draw from the hand. If you ever get an order to draw from a foot of a person, you have to have a doctor's order to do that. But in these day and times, nobody's drawing from the foot, because if you are a hard stick as a patient, meaning that they can never get your veins, they have better techniques where the doctor inserts what we call a central line that's here, or a PICC line that's in your arm, and it stays there. So you get medicine through it and your blood is drawn from it. So there is no longer, what I can see, not too many people drawing blood from the foot. But if you are tested, you can draw from the foot, but only with the permission of a doctor, and the order has to be in their chart. Okay to draw blood from foot, okay? All right, so I just wanted to give you these examples of arteries and veins, because that is our circulatory system. That's what we have. If anybody has a hard time getting oxygen from the brain to the fingers to the arms to the feet, it's not good. Every single piece of our body needs oxygen, okay? All right, moving right along. Let me go here to what I have written in black underneath my medical terminology image. Now, On page 23, it talks about POCT. And I did explain to you on Sunday that I was going to talk more about POCT. When we dipped the urine and read our urine strip and got the results right then, technically, once you get faster, right? And when we stuck each other finger and put the blood on the strip, and we got our blood sugar results right there, right then. Let's just say when COVID was really big, they were doing rapid testing, meaning they did a COVID test and the results came in 15 minutes or so. Let's just say you do a flu test in the office and it's called a rapid flu test. The doctor does a flu test and they get the results right back in 15 minutes, technically kind of like while you're still there. I said all of this to say, POCT stands for point of care testing. It means any test that is done on a human that is in the presence of the patient or that you basically get back within 15 minutes or so. So it's any rapid testing, any test that you get back within 15 minutes or so. In other words, any test that you do the testing for that you do not have to send to the lab to get the test rapidly, to tell me I have strep throat, to tell me I have a flu, to tell me I have COVID, or to tell me I have a urinary tract infection or such. Remember, as the phlebotomist, you're doing the testing, but you're not telling the patient what they have. Those results are recorded and faxed to the doctor's office. Remember, the most secure way to get the results to the doctor is per fax machine, okay? The doctor is going to call me up and say, Miss Chopin, your results came back and you do have COVID, blah, 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 okay? So point of care testing means any test that is done near or in the presence of the patient that you get the results back rapidly, which is basically 15 minutes or so. Examples is a blood sugar test, a pregnancy test, a rapid COVID test. There's a stool occult test that if you smear some bile on the card, it gives you results if there's blood in the patient's poop that will let the doctor know, okay, they need to go for further testing because having blood in your poop is not a normal type of thing. Yeah, Keela, it's something. So being in the medical field and even just being a phlebotomist, you can learn a lot. And like I said, this sometimes increases if you like it or is inquisitive and healthcare is you. This is what's going to make you want to do more things. If not go to school for other things, at least move up in the chain in the lab world, okay? Stool occult test, strep throat, and rapid flu. All of those are examples of point of care testing, okay? Point of care, and you will see that on the exam. So I just need you to know what POCT stands for, and I need you to know what point of care testing is. Just remember, any test on humans, I keep saying that because some of those questions will say something about animals. We're not veterinarians, okay? Now, can you draw blood on dogs or get their samples? You can, but you need to go to the veterinarian place for that, okay? But just remember, we're talking about humans because in order to work in a lab of that extent, it is of human, bodily fluid. So just remember POCT stands for point of care testing. And just remember that point of care testing means that you can do something, you can test something from a patient while they're still in the clinic, because you could work for a doctor's office that have their own lab. So I'm here waiting in the doctor's room and you're just in the next room. And then when you result it, you walk over, give the result paper to the nurse or the doctor. Then the nurse or the doctor comes in and give me my results. You did it while I was there, okay? Or it just came back in 15 minutes and the nurse or whoever called the patient at home and say, your flu test came back, okay, positive. So you have the flu. All right? Let me know if you have any questions from that. Now, next on our list, we have pre-analytical errors, and it explained to us on page 105. And just as simple as I can put it, ladies, pre-analytical errors means any error that occurred before the specimen was even tested. Let's just say you went out of the order of draw. Let's just say you drew blood on the wrong patient. Okay, you don't want to do any pre-analytical errors, but that's what that medical terminology means. So what is there for, just for you to have an understanding what pre-analytical error means. And it means any error that occurred prior to the blood being tested. You may not even knew that you did that. You may not even realize you went out of order of draw. You may not, I mean, you should be able to realize you drew blood on, I mean, you know, you have the wrong patient to correct that. But just be mindful. Also, labeling, putting the wrong label on the wrong tube. It's all my blood and you use my labels, but you put a CBC label on a PT, and I explain that, you know, when we get into the order of draw. So all of that is errors you did before the sample was even tested, okay? In your book, it is explained on page 105. Errors that occur prior to testing a specimen are called pre-analytical errors. Careful phlebotomists can avoid these errors most of the time. Misidentification of a patient or a specimen is one of the most common errors in phlebotomy. It is also one of the most dangerous. Before a specimen is drawn, the phlebotomist must identify the patient by 2 unique identifiers. Most commonly, this means asking the patient to state their name and spell it, and his or her, and their date of birth. This is information must be checked against the patient's wristband in an inpatient facility and against the requisition in an outpatient facility. So just be mindful. So you may ask, well, what we need to know about this word, just know what it means. And it means an error that has been done way before the test gets to the lab, the sample gets to the lab. Okay. Back to informed consent and implied consent. It is explained to us on page 24. We did slightly go over it on Saturday when I showed the roles and responsibilities video and the ethics part of phlebotomy. Just know that informed consent is used for bigger procedures and surgeries, meaning that if you have this surgery or if you have a blood transfusion, you may be one of those ones that work there in a place that a patient gets blood transfusions, or you may be able to be in the room when the nurse starts talking to a patient about they have to have their gallbladder removed. Remember, a regular general consent is different from big procedures. Remember, when you checked into the ER, you signed a general consent to be treated, just to be generalized treated, regular blood draws, medication to be administered. But while you were in there, if the doctor determined, oh, her gallbladder or her appendix needs to come out, that's what's going on with her. That's more of a bigger surgery. You have bigger risks. So the doctor or the nurse does an informed consent. That way they have to explain the risk and the risks that can happen, and they have to sign it. Versus an implied consent can be just talking to the patient verbally, which is what most laboratories do. Okay, you want to inform the patient of implied consent is you letting the patient know that you're the phlebotomist and that you will be drawing the blood. Is it okay that I draw your blood? Let's just say, I mentioned to you guys, if it's in an emergency situation and the patient cannot speak for themselves, they're unconscious. There is a scope of practice and a rule to where everyone is considered to want their life saved if you don't see a piece of documentation or will or a power of attorney type thing. So the patient implies that he wants medical attention. Let's just say the patient comes into you and you're outpatient and he is deaf, so to speak, but he can read lips. He's over 18, so he really doesn't need a guardian or no one at all. Okay. Let's just say he can read lips, and then you ask him or you write it down, and he basically either writes down his answer or he takes off his jacket and gives you his arm. So the gesture it's a nonverbal communication, but he is implying he's okay with you drawing his blood because he took off his jacket and gave you his arm. Okay. Same thing if you're a phlebotomist in the hospital. Let's just say Mr. Brown, he have tubes down his neck.
Miss Juanetta.
Huh?
So we don't need to wait for like a shake of like yes of the head, like a yeah, I can do that.
That's
Like
the
him just
same
taking
thing.
off his jacket and sitting down is
That's the
is
same
good to
thing
go.
as him giving you like that means he understands and he's agreed. Some
Okay.
people won't shake their head. If they do shake their head, that's still a way of nonverbal communication, either or. Don't let that
Okay.
confuse you. Because even if he shakes his head, he still have to take off his jacket and give you his arm, right?
Indeed.
Yeah. So just be mindful of that. So the same thing in the hospital. Let's just say you're a phlebotomist in the hospital. Mr. Brown has tubes down his throat, so he can't talk. He is an adult. He is up and alert. So he knows that you're there. He understands what you're saying. And let's just say he gives you his arm. So he is implying to you he wants his blood drawn because it is documented that person that is deaf, that can't speak. It's no way for you to say, I was waiting for him to speak, or he can't tell me. Well, he's deaf, so he can't tell you. He can't speak. Mr. Brown, he has tubes down his throat. He can't speak, but he did give you his arms. You have to think about the situation and use your judgment. Mr. Brown, maybe he can nod his head, but in order for you to draw his blood, you have to also have his hand or his arm. Okay. So just be mindful that implied consent is a form of verbal and nonverbal communication. And it is used in emergency situations, and it is used for nonverbal situations. We already know that it's used for verbal situations because if this person has no disability hindering them at all, they're able to say, yes, ma'am, and give you their hand and arm because you have to do that anyways. Okay. So be mindful of implied and consent. I want you to be mindful of the difference, but you're going to be tested more so on implied. But informed could be an answer. So if you're confused on the question that is meant to be implied, just be sure to study the two. Just remember, informed consent is informing the patient of his or her risks of the procedure or the surgery, and it requires a signature, not just a verbal understanding, because now they're at bigger risk. And in phlebotomy life, you will not be given an informed consent because what you're doing is not of a big statute of big risks. Did I lose anyone on that?
No.
No.
Okay. Because you'll see it a lot. You will see it a lot. Okay, sorry about that. I know that we at time. Do you guys still have a little bit more time?
Yes.
Okay, if you don't have time and I see you fall off, no worries. This is being recorded. Okay, I just want to go over all my stickies and it shouldn't take me too much longer. Next, after implied consent is standard precautions. We already should know what standard precautions is, okay? The test is going to have it about 5-7 times, and it is just easy as can be. Standard precautions means we wear gloves because we assume all bodily fluids have bacteria, germ, or some type of microorganism. So we always use gloves. Right here, I will go into PPE, personal protective equipment, on Sunday when we do CPR and when I do the other precautions. But this is examples of PPE. Any personal protective equipment that you have to put on that protects you from catching any type of microorganism from the patient. It could be gown. It could be N95 mask, a regular surgical mask. It could be goggles, and of course, gloves. It can even be the booties we put on our shoes. But standard precautions only require gloves. When a patient has been deemed that they do have a microorganism, then we will have to get suited and booted with the other personal protective equipment, okay? And as you can see, the yellow biohazard bag, that's where once we take off this stuff, that's where that would go. It's not filled with, it doesn't have any contact with blood, but yet it is of something that could be contaminated. So we put it in a yellow biohazard. Okay. Let me move on to my green sticky note. Give me 1 second. Let me move this down. My little pictures. All right. So I want to do it quickly, but I don't want to do it in a rush manner. So my green sticky note here. The first word on the list is pronounced syncope. SYNCOPE. What that means is feeling faint or actually fainting. We heard Miss Tracy say all weekend that she's never fainted before, but her hands be getting sweaty like she feel like she's about to faint. The medical terminology word for fainting is pronounced syncope, okay? My little picture over here with the lady to the side, she may feel like she's gonna faint. So on this weekend, we will go over complications on if this should happen in front of you, what is the best way for you to react? What should you do? So remember, that's why we asked that complication question in the beginning, so we could be prepared. You know, if your lab have a reclining chair, then Miss Tracy may have to be the one to sit in that recliner. So therefore, if she do feel lightheadedness, she will be able to come to, or if she actually really do lose consciousness, she's already in a reclining position. Or a person could lay down, can be lying down, so to speak, okay? But if you don't have a recliner or a table, and if someone tells you that they feel faint, you stop what you're doing and have them lay their head down on the table until that feeling goes away, okay? Syncope, feeling faint or actually fainting. It talks about it in your book on page 34, and it's just as simple as could be. For example, the medical term for fainting is syncope. Simple. It's pronounced syncope. I do need you to know how to I need you to know how to recognize this word, or I need you to recognize this word, and I need you to know the definition. Syncope, feeling faint. Okay. Next, edema, fluid in the tissue, meaning that someone looks like they're swollen. Have you ever, like my image here, this person's feet, ooh, they're really poofy. And when you touch it, it does an indentation like that. That's nothing but fluid. I need you to know the medical terminology of fluid, and that all that fluid is in the tissue. Just like how blood can be in the tissue and cause a hematoma, well, this is fluid in the tissue, okay? And it's named edema. If my hands is swollen or my antecubital fossa area is swollen, do not draw from it. The moment you puncture through and stick with the needle, nothing but fluid is going to come out. As a matter of fact, if someone has so much fluid, you're not going to really be able to feel the vein because the fluid is superseding what you're feeling. It talks about edema on page 157, and it's just as simply put as that. Edema is fluid in the tissue, okay? Just that simple. On page 157, it talks about it. Matter of fact, on the same page that we did for our capillary sticks. Patients with edema or swelling of hands are not good candidates for capillary punctures. Their capillary blood is likely to contain a high volume of fluid. So we don't stick fingers or draw from the hands or from the antecubital fossa if we see fluid or if it's swollen, okay? Edema, fluid in the tissue. Next one is pronounced petechiae, Petechiae. I know it'll be hard to pronounce or it's not as easy, but petechiae. I need you to recognize that word and know the definition if pronouncing it is difficult. Petechiae is small red purple spots on the skin that may look like a rash, but really it's broken capillaries, like this picture on the side of it. This person looked like he or she has a rash, but it's really called petechiae. And the reason why you will know that it's not a rash, because it could be something, nothing that you did. Someone else can just have, you know, small issues, or they could be fragile when you draw their blood. Or you can tie the tourniquet tight and all of a sudden it may have underneath in the skin, bust a capillary, so to speak. Remember, when we talked about capillaries are very small blood vessels. They are smaller than the veins. They are smaller than the arteries. That's why when we do capillary punctures or dermal punctures, the blood that lies in our bodies just flowing freely, that's capillary blood. So you can tie a tourniquet, you know, pretty firmly or tight, or maybe it wasn't even tight. And all of a sudden you just start seeing these red purple spots pop up. If you happen to see that, that should not distress the patient at all. And that does not require you to stop what you're doing. That's just capillaries underneath the skin that's just dispersed everywhere. But on top of the skin, it looks red and purple like a little rash or like little bitty micro bruising. That's what that means. Have I seen it often in my career? I haven't really seen it often, but you are tested on that knowledge. Petechiae. It talks about it in your book on page 145. Give me 1 second. Phlebotomy technicians should be aware that some patients may develop a rash-like condition known as petechiae. After a tourniquet is applied, these small flat red or purple dots are created by the leaking of blood from capillaries. Petechiae may be associated with a number of different health conditions. Their appearance is not cause for discontinuing the tourniquet use or stopping the venipuncture. It's just, you know, a disbursement of blood. Now, real life experience. If the patient demands you to stop or say they feel any kind of way, don't take a chance. Just stop doing what you're doing. And they could be being dramatic, you know, but just stop doing what you're doing. In a way, they're kind of refusing in the middle of the treatment. I mean, refusing in the middle of your draw for you to continue. Don't make your job hard. Just go ahead and stop. You know, that's just, you know, for, you know, just to give you some real life experience, because the patient may see petechiae forming, not even hurting or nothing, but they say, oh, you need to stop. I think you need to stop. Just stop, okay? Talk to your supervisor about it. Let him or her guide you further. Remember, you always have a supervisor, but technically petechiae doesn't cause harm for you enough for you to stop your blood draw, even if you had all the color tubes in the order to draw, okay? Moving right along, aseptic or antiseptic technique. We kind of talked about that. That means the technique that you're using is making sure that that spot or that area is free from bacteria or microorganisms. That's why we use 70% isopropyl alcohol or the ChlorPrep, which is the chlorhexidine gluconate. Make sure we're always using aseptic technique. Remember, iodine is a form, but we really don't use that unless it's more of a sterile purpose, because you're drawing the patient blood because he's going to have his appendix taken out and they're already prepping him for surgery. So, okay, the doctor tells you to go ahead and use iodine, long as they're not allergic. Okay, so just remember, aseptic and antiseptic technique, it will be on the exam. Next, ASAP and STAT. If you haven't seen these before, it means as soon as possible, immediately. Let's just say you was a phlebotomist in the hospital. You had 4 patients that orders came through. 2 of them is STAT, and the other 2 are just regular blood draws. You're probably like, which one I'm gonna do first? You just get to them as soon as you can, because STAT typically means they need to be drawn and in the lab to be resulted for that doctor in 2 hours. So you getting the order, going to the patient, drawing the blood, sending it to the lab, and the results coming back should be no longer than 2 hours. So you just use your judgment. If you get a bunch of stats and there's co-workers there, you may want to tell your supervisor, is it okay, that Akila works with me because I have 2 stats right now. So just know that ASAP and STAT means as soon as possible. Those supersede your other blood draws because it's STAT, okay? Because that means something is going on with the patient enough that the doctor ordered it STAT and he needs those results right away. Because typically regular blood draws, when you draw blood the regular way, they come back the next day or 2 days just for regular blood draws. But he wanted back the same day in less than 2 to 4 hours. Disinfectant solutions are for surfaces. It is always bleach mixed with water. And what I mean by surfaces, I do not mean the skin. I mean counters, faucets, floors. Remember, do not get yourself confused with antiseptic technique versus disinfectant solutions. When we use alcohol and chlorhexidine gluconate, that's not considered a disinfectant, even though your brain is like, oh, I'm cleaning the skin, I'm disinfecting the skin. But in medical words, it's called using aseptic technique to be sure that that area is free from any germs or bacteria, okay? Disinfectant solution is always mixed with bleach and water. If you work in a medical facility now and whatever disinfectant they use, I want you to pick up and look at the ingredients. It's going to be bleach, okay? So just know that bleach, ooh, them little mosquito thingies. Just know that it is mixed with bleach, okay? Do I have any questions for you ladies? I know I held you over an hour. I'm so sorry, but I do want to be sure that I explained all of that. I will go over the positions here on tomorrow. I will start with that tomorrow. Capillary puncture, we already really went over that on Sunday for the most part. I know Ms. Araceli, we still have our meet, but we'll go over that. But capillary, I've already explained to you all, is the smallest blood vessels that contain both venous blood and arterial blood. An example is what we did with our finger sticks. And this is a image of the blood vessels, and you see the artery and the vein. And then in the middle, that's the little bitty capillaries that is in our body. Okay. Do I have any questions? I really thank y'all for staying on over the time.